Ellen, thank you so much. And really, I hadn't quite realised how clearly overlaid, the vision of Healthier Together and some of the outputs are with this strategy and vision of the RCPCH. So,
Yeah.
really encouraging to hear that this really is going to be a really powerful, strong relationship moving forwards. Do you know what we might do is if I get the 5 speakers actually to put your cameras back on, we've had some questions on the chat. We'll make this about a 15 to 20-minute Q&A session, which I'll facilitate. I'll start with a question for Alison, actually. If you're still there, Alison.
Yeah.
Fabulous. A question from Pip, who's based within the LD and autism team in Surrey, and well, I can't even read my own writing, but from Surrey, let's say that. She's spoken about the variation in the quality variation in terms of the care delivered and the knowledge of professionals. You articulate that sort of heat map with the various colours, show how many different providers are included, but within a provider group, and let's just say health visitors for now, in terms of this question, there's clearly variation. And although we're never going to totally remove that variation, how do we, what would be your vision for improving that within health visitors?
Yeah, no, really good question. And the first thing to say back is that huge apologies if you've had not great care. It makes a massive difference, and it's certainly not what we're hoping for. And there are 3 issues that really drive it. The 2 I mentioned, particularly on the slide, was obviously funding and workforce issues. So if you've got a workforce that's pushed for time, people take shortcuts. People don't get back to people get lost in systems. That's when care suffers. And there's a human cost to that, which is clearly felt by families. But the third bit is this unwarranted variation across the country, which is massive. So health visiting shifted to the local government in 2015 at exactly the same time as the funding got cut. Cause and effect is really hard to unravel. But what it did do was it opened up this local decision making, and that's local decision making at every level. So that's in terms of the quality of services delivered, in terms of staff CPD access, research, everything is varied across the country. And some areas are delivering absolutely fantastic services, and others, families are getting literally virtually nothing, and it's not good enough. And so within that, there's a health visitor capability issue. So if staff aren't being sent on courses and investing in their development, then services suffer. And so fundamentally, I've worked in a failing trust previously, and the way we turned it around was we trained our staff. So as everybody was saying, well, you need to be out there doing, every minute that you're working, you need to be out seeing families. Actually, no, when your service is broken, you need to be fixing your staff, and you need to be investing in them as the smartest of all investment, and giving them the confidence and the space to actually do the job that they're trained to do. And that's the bit that's missing, and the bit that we're pushing for is personalised care with families, and that's a huge skill. So we're doing a lot of work at the IHV at the moment, upskilling workforce as well in that space, personalised care, working in partnership with families. It's not just giving people a leaflet. It's when you alienate families and they feel like they're not listened to. So we're trying to unravel that. But yeah, it's a national problem, I guess is my quick answer. And huge apologies if that's affecting you. We're doing absolutely everything we can. And I know there's some senior officials on this call. We're working with them to try to turn this around, both for the current government and any potential future governments as well.
Thank you, Alison. And a question from me, actually, regarding universal offers versus targeted offers. So we none of us are naive enough to think that we don't have resource constraints, both financially and workforce, in terms of the number of staff we can recruit and retain. Where do you see a realistic balance between what should a universal offer look like? Where does virtual stuff sit within that, and targeting a sort of an improved offer, which we clearly do in this country for children within, that are somehow identified? How does that? Where have we got it right? Is there room for improvement?
I think it depends where you work and where you live. So from the top, proportionate universalism is the linchpin of Michael Marmot's work, and so that's what we're pushing for at the IHV. You can't shift the whole population curve if we only target, partly because making a service universal makes it acceptable to families, and it's the only way. You have to have a systematic proactive way of reaching families, particularly babies and young children who are invisible to services unless families step forward and ask for help. And we know that's the tip of the iceberg. We need to be in there looking for hidden need. So universal is that you can't do early intervention. GPs, pediatricians can't do the work they need to do with complex conditions if we don't find these children. So identifying them has got to be the first step, and that's why we need strong universal services. The question about virtual contacts, so they absolutely have a place. However, they do not have a place in mandated health visitor assessments of babies, young children, and families. And the reason for that is it is impossible. If you look at the schedule of intervention, it is impossible to do it over the telephone. So just for a pragmatic thing, you can't weigh a baby over the telephone. You can't observe for signs of bruising. You can't observe the environment around the child, the parent-infant interaction, which we know so fundamentally, underpins, child health outcomes in so many different ways. You can't do that over the telephone, so we should stop pretending that we can. We shouldn't be counting them. I've escalated this all the way up to the top of the Department of Health because we're ticking boxes and we're missing points. The purpose of the service is to identify needs. So if the mechanism of doing that doesn't do it, we should stop doing it. And we need to do it properly. Our children deserve better. They deserve 5 mandated contacts face-to-face by a professional who can spot nuance and deviation from the norm: physical health, mental health, adult health, child health, social needs, safeguarding, and child development. An awful lot goes on in those contacts, so let's do those properly. The virtual contacts do have a place for follow-up contacts. My baby's got the skin rash. Can I show you over a video call? Could you remind me, if my child's missed his immunizations, or I'm worried about X, Y, and Z? There's lots of stuff you can do virtually. People have run groups, breastfeeding support, perinatal mental health groups virtually, and got good outcomes. So we're not saying don't do it, but just don't do it for the assessment contact. And then in terms of targeted support, when you identify a need, it's absolutely fundamental. We have services to pick up that need, because it's ethically wrong, I would say, to raise awareness and do nothing about it. And that comes all the way back to funding. We need to take our children's health seriously, and it needs much, much more investment. So it does come down to money and workforce as well.
Brilliant. Thank you. Wonderful answer, and really clarifies in my mind why that universal offer is absolutely essential. You're right. Otherwise, and we saw that in the pandemic, children and families just get hidden and lost. Okay, questions for Simon and Alex. Brilliant talk about hubs and working between, community primary care and secondary care. One question related to the third sector. It was phrased, we're not just a bolt-on. We're an integrated part of this. How do we truly forge collaboration? Beyond just primary care and a pediatrician. How do we get health visitors there? How do we get mental health colleagues there? How do we get community teams there? How do we get third sector colleagues to these hubs, which then improve morale and make people feel as if they're part of a joined up solution as opposed to fragmented, non-communicating bits? Simon, Alex.
Yeah. So I think one of the questions that I read was about the voluntary sector side of things. And, I in no way underestimate the value of that enormous sector, especially when things are so resource stretched in other areas. They pick up the slack in so many areas of child and young people's care. The difficulty I found, and I really tried to address this head on, is I looked in my patch and I looked at various groups who are doing an enormous amount of work, and tried to work out how I engaged in them in a very short period of time. My MDTs, just to make people clear, because I've read some of the chat, these aren't community pediatric MDTs. These are not, I'm not a community pediatrician. These are literally about 12, 14 questions around the room and around the virtual room saying, I've done this for migraine with this young person, but it's not working. What's the next step? Or literally things like this. So as far as engaging the voluntary sector, there are some tricky parts to that, as in there's a lot of patient stuff and things like that. But actually, it's also quite tricky to say, okay, who's going to represent these sectors? And what you end up is doing it by kind of surrogate. So if you have the health visitor, she'll say, oh, this first fantastic obesity service that we're running in Andover, where I am. Or the GP might say, oh, well, actually, these great counsellors that are working voluntarily for our CAMS patients. And so you you have to use what you've got available. Actually gathering a group of people who are doing great work in the voluntary sector and bringing them to an MDT to give little snippets is quite tricky. And I'd love to know how to do it better, but it is quite tricky. As for getting people like health visitors together, I'm afraid in my area I've now stopped trying, but in other areas they're flourishing, and the interaction is fantastic. In a Children's 4 clinic I did, we had an amazing interaction between the health visitors and GPs about a common thing that was happening that would ultimately really improve the care of babies that we're seeing in the baby clinics. So just because I can't do it doesn't mean that others can't, and there's plenty of health visitors who are very keen.
And Simon, there was another very interesting comment in the chat about family hubs. So national family hubs, there was a big funding call went out maybe a year or more ago, where some of the most, from an index of multiple deprivation perspective, certain local authorities were chosen to develop family hubs. Your previous answer makes it clear that almost the connecting care hubs are maybe not a great forum to bring in, they're quite a targeted discussion. But let's say there are forums for an hour where health visitors, third sector providers come together within family hubs. Do you see that potentially be somewhere where, we can bring in a similar model, although you're talking about not cases of migraine, but maybe cases of multiple presentations to ED, housing bits, absence from school, mental health?
Absolutely. I mean, like I said, there are some hubs in Southampton now I know are looking at the top 5 attendances for, at the beginning of their MDTs every time, and they have a slightly wider MDTs, and there's no reason why these either can't be brought together, these initiatives, or they can't work alongside each other, because ultimately they're all trying to work around a family. And so they're not mutually exclusive. They are slightly different. This was discussed with us a number of years ago, that there was something already happening, or rather that might be happening. I'm not quite clear how they fit together at the moment, but they're certainly not mutually exclusive. Yeah. However, these are not fora in which to talk about one family for an hour. These are, to get the best out of these are short, sharp interactions, discussing cases, and helping lots and lots of groups of people, rather than just one or two in one meeting.
Yeah, very good, Simon. And also very much one size doesn't fit all. And actually these need to be, this beauty of the model you described is it's not a fixed model. It's very much locally implemented with local clinicians, local professionals who work out what the best offer is. And so very good. A question for Matthew, actually. Very lovely to hear about what that vision, and you said at the start, some people ask, what does the NHSE team do for children and young people? I mean, the National Asthma Bundle is a great example of this, very much a move towards integrated care. And my question actually to you is, what, through that implementation work over the last year, what have we learned about improving implementation, co-working with schools, direct messaging to families, primary care, secondary care, and what, how would that kind of, where does Healthier Together sort of sit there potentially?
Thanks, Sanjay. I mean, I think one of my kind of constant reflections is about the power of local clinical leadership. The idea that these things work because someone sits in Wellington House in London and comes up with a policy is really fanciful. So I think it's really important that we acknowledge the importance of local clinical leadership, but acknowledging it isn't just enough. You then got to think about, well, how do you actually foster that? And I think there is things we can do, or we've tried to do, in terms of releasing funding to ICS specifically to employ an asthma lead per ICS and set up a network that could practice around that as well. So I think that local clinical leadership and one asthma lead is probably not enough. It needs to be a series of people across different sectors. But then I think when I think about the Healthier Together approach, it's about actually how do we we don't like to overuse that word network, do we? Because everyone's always setting up networks about everything, but actually there is a degree of networking, if not a formal network, across primary and secondary care as the bedrock. But then very much trying to think about, well, for the hardest to reach communities, primary and secondary care often isn't enough. And, asthma is a condition of school-aged children, and most children go to school. So you do come around thinking quite quickly that school nursing is where you would like to target a bit more effort. And there are definitely some really interesting papers in the US where they deliver to hard to reach communities all asthma care through schools. There's all the asthma clinics just happen in schools on the basis that way children actually get in front of the asthma nurse doctor to see as well. So I think it's about having the clinical leadership to understand where the real challenges are, because the best in the world, you're never going to do everything everywhere. And actually, if you've got a relatively affluent part of the world where asthma is really quite well managed, putting in a school-based intervention would not be good use of valuable resources. But I think it's about having a combination of that local clinical leadership and starting to kind of push and share examples of what can be done. And I think that's why this, sessions like this are so valuable, because actually you hear Simon and Alex talking about what they've achieved, and that provides the platform And as I say, it comes down to that local thing, that there isn't a one size, school nursing is organised in very different ways in different parts of the country. So you need to understand how your local school nursing works. And I think thinking about the third sector organisations as well, there are wonderful national organisations. Bernardo's obviously springs to mind, but also there are lots of small organisations that you need people to understand what the needs of the community are, what's available, and actually how do we marry it up for this population in Hull or wherever it is at that time.
Yeah, no, thanks, Matthew. A really thought-provoking answer, and I think that bit about local clinical leadership is spot on, and I think that's what Healthier Together offers. It empowers local clinicians to set up their own networks. We've got a primary care network, we've got an acute network, we've got a mental health network, so that when one wants to implement, say, an asthma bundle or a safe getting to school bundle or whatever, we've already got those relationships in place. And I think that's the real strength of Healthier Together. It actually allows us to implement stuff because people have respect for each other and people have worked together on doing some stuff in the past. That means the trickier problem is easier to work on together when you already know each other. So yeah, we will continue to do that. Now, last question is for Helen. I see that we're already eating slightly into our coffee break. Helen, you beautifully described how you can almost overlay lots of the vision of Healthier Together and the outputs to much of the strategy of the RCPCH, but practically in terms of formalizing that relationship or actually really making the most of those synergies, how do you see that working within the RCPCH?
Oh, I don't have anyone from policy here to make sure I don't say the wrong thing. So I think so the college has, I think it's a joint promotion role, basically. Like, the college doesn't have huge amounts of resources, and actually this is a fantastic website that we can link into, promote. But I think going forward, with me being on the core content committee, I think that does provide a two-way conversation that we can make the most of to find opportunities in the future to work together.
Yeah, no, very good. And I'm sure we will continue to have some discussions with the policy team, etc. Sure. Especially as this gets rolled out, potentially to each ICS in the country. Then it very much is, how do we, as Matthew said, how can we use how can the RCPCH use Healthier Together to get those messages and that stuff out? How can NHS England use it to implement their national asthma bundle? How can the IHV and others use it to promote messages about prevention? And I think the more sites we have on board, then we've got an effector for clinical leadership and for messaging. Thank you all for a hugely thought-provoking first session. I have thoroughly enjoyed it. We've got 10 minutes for a break. We are going to start at 11:15, the next session, which is the digital innovation session. If any of the speakers want to try and answer any of the questions that we've not been able to get to in the chat, feel free. Otherwise, go and make yourself a cup of tea, coffee, and see you all in 10 minutes. And finally, massive thanks to the 5 speakers for a brilliant session. Thank you.